Hello, my name is Amber Pendarvis, and today I'm going to be talking about my particular concussion case study. The athlete is a 23-year-old male soccer player who sustained a head injury when going up for a header in a scrimmage on 9/17/2018. Immediately after the injury, the certified athletic trainer that was on duty did a sideline assessment, including SCAT-5, VOMS, and a cranial nerve screen. Immediately after the injury, the athlete portrayed concussion-like behavior and reported a number of symptoms listed on the SCAT-5 symptoms list. He was told that he was not allowed to participate in soccer or any other activity until he became asymptomatic. On 9/18/2018, the athlete took a neurocognitive impact test. And on 9/20/2018, the athlete took the impact test again, and the baseline scores and the post-injury scores were compared to determine whether he was permitted to continue activity. On 9/21/2018, the athlete was permitted to begin his 6-day return to play protocol. Next, the certified athletic trainer put together a SOAP note. So SOAP notes are split up into subjective, objective, assessment, and plan. So first is subjective. The patient is a 23-year-old male soccer player who sustained a head injury with a teammate on 9/17/2018. The patient complained of headaches, sensitivity to light, sensitivity to noise, dizziness, fogginess, etc. The patient states that his symptoms increased with activity and notes a 6 out of 10 pain out of a 10-point scale. He did have a concussion previously, but it was about 5 years ago. Objectively, no red flags were noted. The patient did not have any neck pain, double vision, loss of consciousness, vomiting, or any weak or tingling in the arms or legs. The sideline assessment included a cranial nerve screen, which was normal, VOMS test, which was normal, and a SCAT-5, which showed difficulty with short-term memory and balance. Next was tested the range of motion. Neck flexion, neck extension, lateral flexion, and rotation were all within normal limits. During the sideline assessment, it was noted that the patient could not stand up on his own due to a lack of balance. He also had difficulty focusing and became very agitated during the assessment. Scars, bleeding, and discoloration were not noted during the assessment, and the final impression of the assessment was a concussion. The next and final part of the SOAP note is the plan. We split the plan into a short term and a long term. The short term was sending the patient home with his guardians with an informational packet explaining what to do should something happen or symptoms get worse, and to pay close attention for the first 24 to 48 hours. The patient was also told to report to the athletic trainer on 9/18/2018 for reassessment and impact testing. Long term, the patient is supposed to report to the athletic trainer every day for symptom reassessment until asymptomatic. Once a patient is asymptomatic, he is still supposed to report to the athletic trainer every day to begin his 6-day graded return to play. There are 6 concussion clinical trajectories. All concussions fall into at least one of these trajectories, and some of them may fall into multiple. The vestibular clinical concussion trajectory includes symptoms of dizziness, nausea, feeling detached, fogginess, anxiety, and overstimulation in more complex environments. An increase in symptoms can occur with rapid head or body movements and just being in a busier or more stimulating environment. The anxiety/mood trajectory includes symptoms of hypervigilance, reflective thoughts, an overall increase of anxiety, feeling overwhelmed, and feeling saddened. Patients with the anxiety or mood trajectory may also report having a sleep disturbance. In this case study, the patient had a vestibular and anxiety and mood trajectory. This is believed because the patient reported headaches, dizziness, nausea, feeling foggy, and he was very agitated. And his symptoms increased due to movements, increased light, and increase of noise. Before returning to play, the athlete must first return to school. You cannot return to play until you've resumed your everyday activities and can withstand a full day at school. Some symptoms to look for are problems causing loss of focus, concentration, becoming irritable, fatigue, more emotional than usual. If the patient or athlete continues to have increased symptoms with academics, additional accommodations can be put into play. Some of these accommodations can be only going to school for half days and working into it, working in a quiet room, having more time for assignments and tests, having a tutor or a student helper in class. The next step is returning to play. An athlete cannot even begin to think about returning to play until they have started their return to play protocol. And you cannot begin your return to play protocol until you have become completely asymptomatic throughout school and regular daily activities. Once this has happened, you may begin your return to play protocol. The athlete must follow the protocol as listed here without skipping any days and without progressing from one step to another more than one at a time. Every day during the protocol, you increase your activities slightly, but you can never go to the next step until the next day. You cannot do more than one step per day. If symptoms do occur, you must stop immediately, and go back to the previous step the following day. It is a gradual increase in activity. Once completing all 6 days of the graduated return to play, you are then eligible to full participation